Today, I'm going to discuss optimizing the spontaneous breathing trial. I will go back to my conflict of interest here. I did receive funding to conduct a large factorial design randomized control trial evaluating screening frequency and SBT technique, but I have no other financial or non-financial conflict of interest to declare. Today, I would like to review the evidence that supports how often we as clinicians should screen patients to identify patients to undergo a spontaneous breathing trial, then how to conduct the SBT, what techniques do we use, how long should the SBT be, and then whether or not we should offer patients a period of rest after a successful spontaneous breathing trial. So as you know, Esteban established that about 40% of the total time that patients spend on invasive mechanical ventilation is actually dedicated to weaning or liberating them from the ventilator. And strategies to reduce the time that patients spend on invasive mechanical ventilation have been identified as a research priority, both by respiratory care as well as critical care societies. So what is the evidence supporting protocol-directed screening to identify patients to undergo an SBT? Well, you may recall back in the late 1990s and the early 2000s that there were early positive RCTs of what we call protocol-directed screening. So having a protocol either led by allied healthcare providers or by physicians to identify patients who are ready to undergo an SBT. But not all the RCTs that were published demonstrated a benefit, especially in selected populations like pediatric patients and neurosurgical patients, and also in highly structured settings like at Johns Hopkins. So Brona Blackwood from Ireland conducted this systematic review and meta-analysis. It's been published now twice. It's been updated in the Cochrane Library. And in the most recent iteration, she summarized 17 trials with nearly 2,500 patients, and she compared protocolized versus non-protocolized screening to identify patients for an SBT. Now, most trials compared once daily screening to usual care, and usual care across these studies required a physician's order in order for healthcare providers to conduct a spontaneous breathing trial. And what she found was that compared to usual care, so us writing an order for an SBT, having a protocol, whether it's directed by allied healthcare providers or by other members of the multidisciplinary team, reduced the time that patients spend on mechanical ventilation, it reduced the time that they spent weaning, and it reduced the time that they spent in the ICU. So protocols are very helpful. Interestingly, though, only one trial compared twice daily screening, or more frequent screening than once daily screening, to usual care in the ICU. And this trial demonstrated some non-significant, but I think important observations that more frequent screening could significantly reduce the time that patients spend on mechanical ventilation and also reduced the incidence of ventilator-associated pneumonia. But no trial in this review compared a strategy of more frequent screening to once daily screening. And you may ask, well, why is that important? Well, because I think, at least from this international survey and some international observational studies, we can pretty well say that once daily screening in the ICU environment is pretty well the standard of care. So to compare more frequent screening to usual care, I think is no longer relevant in clinical practice, that future trials should compare more frequent screening to once daily screening as the control arm. And there have been two pilot trials which I led in preparation for the factorial design trial that we currently just completed, actually. We did some pilot work, including 155 elderly and non-elderly patients, and we really compared at least twice daily screening to once daily screening in these trials. And although underpowered, because they were pilot or feasibility trials saying, can we implement these protocols, more frequent screening was associated with a non-significantly faster time to successful extubation, also non-significantly more successful extubations, but interestingly, it significantly increased post-extubation NIV use. So what can we conclude about screening to identify SBT candidates? Well, the evidence definitely supports daily screening as opposed to usual care. We need additional evidence to understand the net clinical benefits that are associated with a strategy of more frequent screening in our ICU. Should we do it twice a day, once in the morning and once in the afternoon, or multiple times per day in the ICU? We don't know the answer to that. But future trials should definitely compare a strategy of more frequent screening to once daily screening. So what is the evidence supporting specific SBT techniques? Well, we know that clinicians like us conduct SBTs in order to make decisions about timely extubation for individual patients. And inherently, we weigh the risks of a premature failed attempt at extubation, so extubating patients too early, versus complications associated with prolonged ventilation, so leaving the patient on the ventilator and really a too late strategy, identifying them later than they should be. Several techniques are conducted or are used to conduct SBTs, including pressure support with PEEP, CPAP, TPs, automatic tube compensation, and several others not listed here. But again, in our international survey across 6 geographic regions of the world, we found that the two most commonly used SBT techniques internationally are pressure support with PEEP and TPs alone. And respondents to our international survey said they infrequently used other techniques like CPAP or pressure support without PEEP or ATC. In a Cochrane review back in 2014, Ladiera et al. From Brazil pooled together the results of 9 trials that compared really a strategy of weaning that utilized reductions in pressure support plus pressure support SBTs with who cares what people do on the ventilator with the pressure support, but we're going to do daily TPs trials. So it was really a strategy of weaning here, not just comparing alternative SBT techniques. And she found non-significant differences in what we would consider clinically important outcomes in weaning and extubation. In a subgroup analysis of 4 trials, though, she found that patients were significantly more likely to pass a pressure support SBT, which I think we can all understand. That's pretty intuitive. Subsequently, Pellegrini from Brazil in 2016 conducted an updated systematic review and meta-analysis, now included 12 trials in this comparison of alternative strategies, pressure support reductions plus pressure support SBTs versus daily TPs trials, and again found that there was no difference between the alternative SBT techniques in terms of clinically important outcomes, but he suggested that pressure support may be superior to a TPs SBT with regard to weaning success for simple weaning patients. But for patients who were difficult to wean, as Dr. DeMoule just identified for us, or required prolonged weaning, that there was really no statistically significant difference between the alternative techniques. So our group conducted a systematic review back in 2017, and what we really wanted to identify or to compare was alternative strategies when patients were ready to undergo an SBT, don't really care about how they got to that SBT, but we were interested in trials that compared alternative SBT techniques head-to-head. And we pooled those together, and to be included, trials had to report at least one clinically important outcome. So what did we find? We actually identified 31 trials that compared alternative SBT techniques. Most were 2-arm, some were 3-arm. The vast majority of these, 11 trials, compared pressure support to TPs, and 9 compared CPAP to TPs, which I think underscores the most commonly used SBT techniques. So what about the effect of pressure support versus TPs on SBT outcomes, so whether patients pass or fail in SBT? Well, we found no significant difference in 9 of these 11 trials that compared pressure support to TPs SBTs, so non-significant in terms of the SBT outcome, whether they pass or fail. However, when we looked at whether patients were successfully extubated, and remain successfully extubated using the author's definitions, that could be 48 hours, 72 hours, 7 days, we found that pressure support SBTs significantly increased the likelihood that a patient would remain successfully extubated. And actually, patients were about 6% more likely to be successfully extubated with a pressure support SBT. So no effect on SBT outcomes. outcome, but more patients will remain successfully extubated after a pressure support SBT. And when we look at the summary of findings table and grade, we see that there was moderate quality evidence for both of these outcomes, the effect of pressure support versus T-piece on SBT outcome, as well as the effect of pressure support versus T-piece on extubation outcome. So pretty good certainty or high quality evidence. We also a priori plan to look at a subgroup analysis of the pressure support versus SBT or T-piece SBT trials to look at the pretest probability of SBT success, so not extubation success here. And what we found was that the low quality evidence came from the operative trials or the trials in which patients were mechanically ventilated for less than 24 hours. And it makes sense because these patients have a high pretest probability of being successfully extubated. And when you pool these in a meta-analysis, you often see success rates of 100% versus 98%. And so they don't really add very much to your pooled analysis. So low quality evidence, but really where the high quality evidence came was from the non-operative trials, the trials in which patients were mechanically ventilated for more than 24 hours, where we would consider patients to be at intermediate or low pretest probability of being successful on an SBT. So how have our guidance statements evolved? Well, going back to the task force on weaning that Dr. Demoule just reviewed for you in 2008, the SBT techniques that were highlighted here were either T-piece or pressure support SBTs, plus or minus PEEP, and they recommended 5 to 8 centimeters of water here. And then if we look at the ATS ACCP guideline from 2016, now T-piece SBTs are no longer recommended in the literature. It's actually pressure support plus or minus PEEP SBTs. So after the consensus guidelines came out from ATS and ACCP, this large trial conducted in Spain appeared in JAMA. And what they really did was they compared a less demanding SBT strategy, so pressure support for 30 minutes, versus what they considered a more demanding strategy, which was a T-piece SBT, but this time it was a 2-hour SBT. And what they found was that successful extubation occurred significantly more often in the less demanding pressure support SBTs for 30-minute strategy, and that there was no difference in reintubation rates. But curiously, they also found that there was a significantly lower hospital and 90-day mortality associated with pressure support SBTs. So again, more evidence supporting pressure support SBTs. So in parallel with our clinical systematic review and meta-analysis that I presented to you, Michael Sklar at St. Michael's Hospital led a quite a novel physiologic meta-analysis. And what he wanted to do was to look at the effect of alternative SBT techniques with regard to the work of breathing and the pressure time product. And what he found here is when you compare physiologic studies that, when you pool them together, physiologic studies that compared pressure support versus T-piece SBTs, that pressure support SBTs actually reduce work of breathing, and they reduce the pressure time product. So meaning that pressure support SBTs reduce respiratory effort. So in these, in brackets there, I have 142 events and 129 events, so very considerable amount of events in this analysis, but there was significant heterogeneity. So studies had quite opposite findings of 78 and 73%, and we don't know the impact of this on SBT outcome or extubation outcome. In the same meta-analysis, though, he also showed something very interesting. He compared the pre- and post-extubation work of breathing and pressure time product effects during these SBTs amongst these physiologic studies. And what he found was really only a 0-on-0 SBT versus extubation actually mimicked the findings of extubation. So there was no effect on work of breathing of a 0-on-0 SBT, and there was no effect on the pressure time product. So again, maybe it's suggesting that a 0-on-0 SBT more accurately reflects post-extubation work of breathing. But again, there were few measurements here. I highlight 43 measurements in the work of breathing and 32 in the pressure time product. So when should we use a T-piece SBT? Well, it depends. It really depends on your pretest probability. And this is just my interpretation of the literature, is when you think patients have a low likelihood of extubation success, so there's considerable or high uncertainty regarding their ability to breathe on their own, and that's when you want to prioritize a low false positive rate. And to me, that's the time that I want to do a T-piece SBT. But on the other hand, if you look at the converse, when you do a T-piece SBT in a patient who's at a high likelihood of being successfully extubated, you run the risk of getting a false negative and leaving that patient on the ventilator. So again, it kind of depends on your pretest probability. So for conducting SBTs, personally, I'm not convinced that everybody needs an SBT. I showed you that analysis of operative and non-operative where, in one arm there's 100%, in another arm there's 98% chance of being successful. I'm not 100% convinced that those patients that have a high pretest probability of being successfully extubated need any SBT, to be quite honest. Questions regarding the best SBT technique to use may be particularly relevant, though, to those patients who are at an indeterminate or low pretest probability of being successful on an SBT or of being successfully extubated. And we can see from the data that I showed you that really the clinical and the physiologic systematic reviews and meta-analyses are not congruent. Michael Sklar's work definitely favors T-piece or 0 on 0, whereas the clinical data seems to support pressure support plus or minus PEEP SBT. So clearly we need more data. But one overriding interpretation of this is that even if pressure support SBTs underestimate post-extubation work of breathing, they may facilitate our extubation decision-making as clinicians at the bedside. And they may, as a result of that, they might result in more timely and more successful extubations. So what is the evidence for SBT duration? Well, actually, there's nothing in the literature. There's no systematic reviews and meta-analyses. I was able to identify 4 trials in preparing for this talk, one that's published in abstract form only, and for the heck of it, I pulled them together. And so what did we find? We found that a 20 versus 30 minutes, some trials use 20 minutes, some use 30-minute SBT duration as the short arm versus 120-minute SBTs as the longer duration arm, that there was really no difference between them with regard to whether patients passed or failed an SBT and the reintubation rate. But again, shorter SBTs seem to result in fewer extubation failures, and this did achieve statistical significance. So this hasn't been published. It was just for fun that I pulled all of this together. And you may recall on the slide where we compared the task force on weaning versus the ATS ACCP recommendations that the ACCP ATS recommendations made 0 recommendations regarding SBT duration because no data has been pooled in the literature. So I think 30-minute SBTs are okay for most patients. The problem is we don't really understand who needs a longer SBT. That's not really well teased out in the literature. And we really don't know, as Dr. Demule highlighted already, what is the optimal SBT duration in patients who fail an initial SBT. Are they a different cohort? So this is a cohort that needs to be studied. And finally, what is the evidence for rest after a successful SBT? Well, this is really a tale of 2 clinical trials. One trial that was 17-center RCT from Spain that randomized patients who were invasively ventilated for 12 hours to either direct extubation or 1 hour of rest after a successful SBT. And they found a statistically significant reduction in reintubation rates, favoring the 1 hour period of rest after a successful SBT. And similarly found a reduction in post-extubation respiratory failure, which achieved statistical significance favoring resting the patients on the ventilator. But conversely, another multicenter RCT from Brazil was published shortly thereafter, used the same patient population invasively ventilated for at least 12 hours, compared the same 2 strategies, no rest versus rest for an hour, and they found no difference in clinically important outcomes. But they did find in a pre-specified subgroup of patients that were labeled high risk for reintubation, patients who had been on mechanical ventilation for at least 72 hours, they found a statistically significant reduction in the reintubation rate amongst that cohort of patients. So again, another cohort of patients that needs to be further studied. So really, this is my final slide, but what's the take-home message from all of this review of the literature? That daily screening, I think, is the minimum threshold that we should be using in clinical practice to identify patients at the earliest time that they're eligible to undergo an SBT. When we do an SBT, I think at present the literature, at least the clinical literature, favors pressure support plus PEEP SBTs. It seems that shorter, so 30-minute SBTs, are good for most patients. Again, the caveat, we don't know who needs a longer SBT, and that the evidence is really unclear about whether a period of rest is warranted after a successful SBT. And with that, I'll conclude. Thank you very much.